Our next speaker is Dr. Suzuki from Keio University, Tokyo, and his presentation is Posterior Spinal Fusion for Osteoporotic Vertebral Fracture with Neurological Deficit.
Thank you for your introduction. I am Satoshi Suzuki from Keio University, Tokyo, Japan, and it's my great honor to present here. And today's my topic is about posterior spinal fusion for osteoporotic vertebral fracture with neurological deficit. I have no concern with this conflict of interest. So the osteoporotic vertebral fracture, the prevalence of OVF is increasing as to the global aging population. For example, in the US, 54 million people aged 50 and above are diagnosed with osteoporotic, and with 2 million experience OVF. In our country, the population of 65 years or more is over 29%. So the OVF becomes a common fracture. As you know, the OVF predominantly occur in the thoracolumbar region. However, the OVF in the lumbar spine is not rare in case of severe osteoporosis. So the most cases can be managed conservatively. However, failure in conservative treatment for OVF may lead to delayed non-union or vertebral collapse, leading to neurological deficit. In the previous report, delayed non-union, known as Khmer disease, occur in about 7 to 37%, and neurological deficit occur in approximately 3%. The pathomechanism of OVF with neurological deficit consists of three parts. One is secondary to posterior displacement of bone fragments into the spinal canal. The second one is a progression of spinal kyphosis, and the final one is instability of the fracture site. So the several risk factors of delayed or non-union has been reported, such as long-term glucocorticoid therapy, diabetes, and algorithm. And also the radiograph factor is also useful for predicting prognosis of OVF. Middle column injury and T2 weighted image, low signal intensity change, and T2 weighted image, high signal change could be a risk factor for OVF. So the cases with neurological complications should be treated surgically. The purpose of the surgery for OVF with neurological deficit is to decompress the spinal canal directly or indirectly, and to correct kyphosis and restore the physiological curvature through some surgical approach, and to stabilize the fracture site using instrumentation or augmentation. However, to decide approximate surgical strategy to treat OVF is very challenging. So the Shen et al. Published a systematic review in 2016, including 29 publications encompassing 596 patients of OVF. In their report, the anterior approach was performed 36.6%, and posterior approach was performed 60.6%, and combined approach was performed 2.6%. As I shown in this slide, the combined approach took the highest blood loss volume, followed by posterior shortening surgery, showing the invasiveness of the surgeries. So as you know, the OVF patients are often accompanied by advanced age, serious comorbidities, and severe osteoporosis. So we should take consideration for the conveniences. So Mirza et al. Proposed a surgical invasiveness index in 2006, consists of 6 weighted surgical components. And the index correlates with not only blood loss and operative time, but also the surgical site infections. So for example, the 2 above 1 below short posterior fusion, the index is 7 point. However, the 2 above 2 below combined approach fusion, the index was 14 points. It's a double. So the next, we should take consideration for not only invasiveness, but also the clinical outcomes and surgical complications. From the same report shows the posterior decompression and fusion PDF group showed a favorable correction of the kyphosis and the lowest complication rate, 4.2%. So the posterior approach is familiar to the spine surgeon and can effectively correct kyphosis. However, there are many options whether decompression, correct kyphosis, osteotomy, vertebroplasty, or augmentation should be performed or not. So we should determine approximate method based on the degree of kyphosis, presence of vertebral collapse, age, and neurological status. Next, to understand the difference between the thoracolumbar and lower lumbar OVF is also important. Our colleague Isogai et al. Conducted 403 OVF patients who underwent surgery for OVF and compare lumbar group and thoracolumbar group after matching. So the result shows that the preoperative local kyphosis angle was significantly higher in the thoracic group compared to the lumbar group. On the other hand, the preoperative BAS score of leg pain was significantly larger in the lumbar group compared to thoracic group. So these results suggest that the main pathology could be different depending on the affected vertebra. So they also investigated the surgical method, and the results show that the thoracolumbar group had a vertebroplasty more frequently, and the lower lumbar group had combined fixation approach more frequently. And the number of fused segments was larger in the thoracic group. So to summarize the surgery for thoracolumbar OVF with neurological deficit, posterior decompression and fusion with vertebroplasty is very common. And we should consider preoperative alignment to determine how much correction should be needed. So next, for the lower lumbar OVF, various surgical procedure has been described, but the optimal procedure remains controversial. Kono et al. Conducted a study. They evaluated the fracture pattern using a Magal classification and proposed a surgical algorithm depending on the segmental instability, stenosis level, and cleft formation. Our colleague Fukuda et al. Also investigated 20 patients underwent surgery for lumbar OVF followed more than 1 year. They used a minimal invasive combined approach surgery using OLIF. And also they divided 3 types according to the damage to the roster and or caudal end plate. Type A is a roster type, type B is a caudal type, and type C is a both type. And they apply the OLIF procedure for 3 types. And they concluded that this procedure can achieve neural decompression, reconstruction of anterior support, and correction of local alignment in a minimal invasive manner. Another study have conducted Nakajima et al. They included 30 patients with lower lumbar OVF who underwent surgery. And they used a different classification system, type 1, wedged collapse, type 2, flat or vertebraplanar, type 3, concave collapse. And the results show that wedged collapse, type 1, exhibiting progressive kyphosis was rare in the lower lumbar spine. And also for patients with cleft formation, they proposed vertebroplasty with posterior spinal fusion is recommended. So to summarize the surgery for lower lumbar OVF with neurological deficit, although there are many surgical methods and techniques, the optimal procedure remains controversial. So the surgeon should consider anterior support as much as possible. So I show you the one case. This is an 86 female. The chief complaint was low back pain and gait disturbance. And she showed low back pain and bilateral leg pain from 2 months ago without trauma, and the pain gradually spread to lower extremity, and she felt gait disturbance. So on the physical examination shows lower muscle weakness and sensory disturbance, as shown in this slide. So preoperative X-ray shows a T12 vertebral fracture. The wedging angle was 90%, and local kyphotic angle was 41 degrees. Preoperative CT shows a crest formation inside the T12 vertebra, and the posterior fragment compressed the spinal canal. The occupied rate was 65%. MRI shows a severe stenosis at the level of T12. So the bone marrow density and tubercular bone score showed severe osteoporosis. However, the patient had no treatment for osteoporosis at the time of injury. So how to treat this patient? To consider approach, fixation, procedure, decompression knot, or augmentation. So we conducted a posterior spinal fusion from T10 to L1 to above 1 below fixation using some kind of augmentation, such as T9 sublaminar tethering, T12 vertebroplasty, and L1 sublaminar hook. The surgical time was 142 minutes, and the bleeding was 50 milliliters. So we also conducted bilateral decompression by a unilateral approach to preserve the posterior elements such as the spinal process and lamina, and also preserve the unilateral facet joint, and use these area for the fusion. So sublaminar tethering for UIV plus 1 was proposed by Dr. Yagi to prevent correction loss and PJK in ASD patient. We also applied to this technique to OVF with neurological deficit to reduce complications. So this is a post-operative cause. The truncus was applied for 1 month after surgery because of the severe osteoporosis. And unfortunately, the neurological status was recovered gradually, and the correction was, wedging rate was changed from 90% to 31%, and the local kyphotic angle changed from 41 degrees to 60 degrees. And there are no complications until now. So finally, I introduced some small our clinical study. We included 31 patients who underwent surgery for thoracolumbar or lower lumbar OVF with neurological deficit and followed up more than 1 year. The data collection was performed demographic, radiological analysis, and surgical factor, including augmentation. So we divided the patient into 2 groups depending on the implant-related complication. This is the demographic data. The mean average was 75 years, and there were 28 patients with thoracolumbar OVF and 3 patients in lower lumbar OVF. The rate of osteoporosis treatment before surgery was limited, 11 out of the 31 patients. So this is the surgical data. The combined approach was applied to 2 cases. The other one is applied through the posterior approach. And the implant-related complication occur 11 patients. The rate was 35.5%, including proximal screw backward was in 5 cases, and distal was in 2 cases, and screw loosening in 4 cases, and UIB fracture in 2 cases. I'll show you the small part of result. And non-failure group had augmentation, especially tethering technique, more frequently. The rate was 1.1% versus 50%. So to summarize my presentation, surgeons should determine approximate surgical for OVF with neurological deficit based on the fracture level, degree of kyphosis, and the presence of vertebral collapse, age, comorbidities, and neurological symptoms. Posterior short fusion, segment fusion with maximum augmentation such as vertebroplasty, hook, laminar hook, sublaminar tethering, and bilateral decompression by the unilateral approach is one of the options for thoracic lumbar OVF with neurological deficits. Thank you for your attention.